Hello, dear colleagues, and thank you to the organizers to welcome me to do a talk for you today on updates on apomorphine infusion. Here are my disclosures. Before I start talking about apomorphine, I need to lay the ground to understand what apomorphine is all about and how we can use it in the everyday clinic. We're talking about patients with advanced Parkinson's, and patients with advanced Parkinson's may have motor complications. Motor complications are not uncommon. As you can see from these old studies, up to 60% of the Parkinson's patients will develop motor fluctuations within the first 4 to 6 years of oral L-DOPA therapy. So that's quite a large number of the patients. But within 9 to 15 years, up to, all of the patients may have motor fluctuations with dyskinesias. And as you probably already know, risk factors would be exposure of L-DOPA, the length of it, the dosage they're receiving, and the gender, probably because we have a way of treating our female patients because they are smaller, have a lower body weight than the male patients. Disease duration does have an effect too on the risk of developing motor fluctuations. To find the patients who've got advanced Parkinson's and could be candidates for advanced therapy or device-aided therapies, this algorithm has been developed based on the Delphi panel study where a consensus was built on what we mean about advanced Parkinson's disease. Advanced Parkinson's disease is not the same as a patient who could benefit from advanced therapy, that is device-aided therapy. But patients that could be good candidates for device-aided therapies are, according to the Delphi panel, patients who have a treatment with oral L-DOPA up to 5 times a day. They have up to 2 hours of off symptoms a day, and they can have 1 hour of troublesome dyskinesias a day. And this algorithm is now called the 5-2-1 algorithm or rule. And this is just a rule of thumb to help you and me to identify patients who could be at a stage in their disease where we should change the lane of treatment for a device-aided therapy. Now, going into apomorphine, to talk about apomorphine and the updates on apomorphine, I need to step back for a second. At the right hand, you can see Andrew Lees, a professor at Queen Square, and he's been instrumental in the treatment with apomorphine, actually all over the world. He described the effect of apomorphine in Parkinson patients back in '88 with colleagues. Later on, a number of other colleagues have shown data that substantiate the effect of apomorphine in advanced Parkinson patients. The left side picture is actually one I've taken myself of one of my patients, and he's treated with apomorphine pump, and maybe you can't see it, but he's been treated for some years, but the skin at the abdominal wall is quite unaffected by this. But you can see the pump is old. It has been used for a long time. So maybe I can convince you that it has been treated for a number of years by that fact. So apomorphine, stepping back to the 60s. It is a non-ergolan dopamine agonist with effect on D1, D2, D3, and D4 receptors, with the lesser effect on the D1 receptors. It has no opioid analgesic properties, so it's not to be compared to morphine. It is short-acting and is very potent agonist with effect on especially also D1 and D2 receptors. When it is injected, there is a latency to motor response for 5 to 10 minutes. So it's quite a quick effect you obtain with an injection of apomorphine. But on the other hand, the effect will continue for only about 1 hour. So it's to be considered as a rescue medication if it's only given as injections. So a few more words about the history of apomorphine. Actually is quite an old drug. It was developed in 1869. And it's based on morphine, heated in an acid environment up to 100 degrees. It took a number of years before the good effect or helpful effect of apomorphine was discovered. One of them was the effect on Parkinson's disease. So from 51, we had a paper by Swab and colleagues showing the effect of rigidity and tremor of apomorphine in Parkinson patients. About 20 years later, Kotches and colleagues showed that there was a significant effect on reductions on and off fluctuations in Parkinson patients. But the problem with apomorphine is the very high hepatic first-pass metabolism, resulting in the need of very high doses if you give it per orally. And the problem was that it affected the kidneys. So the patients had could have kidney failure when it was given per orally. And another problem was the side effects of apomorphine with a peripheral dopaminergic effect with nausea, postural hypertension. So what we were waiting for was another way of giving apomorphine. And where we eventually landed was on giving it as subcutaneous infusions and to avoid the side effects, the dopaminergic side effects. At least in Europe, we can use domperidone. This is not allowed in the States. So a number of studies were done after the introduction of apomorphine as a treatment for Parkinson's disease. Here I listed just some of them, but the problem with these studies are that they are all open label. So what we were all waiting for was a study that looked into the effects in a placebo-controlled double-blind study. But there has been a few studies on the effect on the non-motor symptoms as well. And this is one study from, it's called the EuroInf study, a multi-center comparative observational study, again, open label. But as you can see here, the effects on a number of factors such as the UPDRS part 3 and 4, but more interestingly, the effect on some non-motor problems. And you can see there is good effect on sleep and fatigue, on gastrointestinal problems, urinary problems, sexual function. And some of these are to be compared with the effect of duodopa. But now turning to the study, the pivotal Toledo study that we were all waiting for. It is double-blind and placebo-controlled double-dummy study. And as you can see from the lower graph here, there was a run-in period, and then there was a period of active treatment. You can see it here in another way. The patients were treated from week 4 to week 12 with either apomorphine or a placebo infusion. So all patients were carrying a pump, and the per-oral treatment was reduced as much as it could be during this study, but mainly within the first month of treatment. And 107 patients were included. And here you can see the results published in the paper by Regina Katzenslager and colleagues. You can see here in the upper left cartoon the effect on off time. And it was significantly reduced in the active arm. The on time without troublesome dyskinesis was significantly increased, which was the on-time without dyskinesias in total. The on-time with non-troublesome dyskinesias or on-time with troublesome dyskinesias in the post-hoc analysis was unchanged in the two groups. On the bar under this, you can see the change from baseline until week 12 in off time. And the interesting thing about this is that the effect continued within the 12 weeks of double-blind observation. And in the right side, you can see the mean change in various motor states from baseline to week 12. And from here, you can see the time spent on without troublesome dyskinesias. And again, you can see that the effect continued after until the 12 weeks period. The patients were asked about their global impression of change, and it was significant in the active arm. And in the last graph, you can see the mean change in peroral L-DOPA or dopamine equivalent doses. And there was a significant reduction as expected, and the reduction continued within the 12 weeks of observation here. A few words about side effects. We've known about side effects from the open label studies, but what the Toledo study showed was actually it confirmed what we knew already, that a number of patients will have local site reactions, but very few patients were excluded from the study due to this. You can see there are only very few patients with major problems with site skin nodule formulation. A number of patients had nausea, about 22 patients in the active arm and about 9% of the patients in the placebo arm. And about the same number with somnolence in the active arm. And that's all we see it in the real life outpatient clinic as well. Some had worsening of dyskinesias, and you could argue, well, didn't we reduce the peroral treatment sufficiently? Some had headache and some had insomnia. There were 9% of patients with serious adverse events, and as you can see in the bottom bar, the ones that led to withdrawal from the study were in 6 patients. One had visual hallucination, one a severe myocardial infarction, which we didn't prescribe to the apomorphine treatment. One had moderate gait disturbances, one infusion site erythema, one persistent abnormal hematology, that is hemolytic anemia, and one had severe hypotension. Now spending a few seconds on the neuropsychiatric adverse events. Until the Toledo study, we thought that we should be very cautious about giving apomorphine to patients due to the risk of neuropsychiatric side effects, or giving it to patients who had neuropsychiatric problems before starting the treatment. In the active arm, there was one patient who had mild hypersexuality, but it resolved when the dose was reduced. 2 patients had mild ponding, but it resolved by itself or with a reduction of the dose. There were 3 episodes of confusion, but it was in the same patient, and it resolved with reduction of the apomorphine. One had mild psychosis, and again, it resolved, and in this instance, without a reduction of the apomorphine dose. 2 cases of hallucinations, one mild that resolved without changing of dose, and one moderate that resolved after cessation of the drug, study drug. So this patient stopped the treatment. In the placebo group, there were also patients with mild confusion, 3 of them, 3 cases in 2 patients, and 2 with mild hallucinations. They all resolved. But what's worthwhile looking into is the clinical difference in the groups looking at the Epworth Sleep Scale score. There were no differences. So the somnolence that we're afraid of in apomorphine was not shown in the Toledo study. And that goes for the Columbia Suicide Severity Rating Scale as well. So no patients with problems with suicidal ideations. And that goes with the QIP as well. The QIP is a questionnaire for impulse control problems. So there was no difference in the two groups, the placebo and the active arm, considering impulse control problems. There's now been published the long-term safety follow-up in following the Toledo study, and I'll share some of the data from that study with you as well. So this is a long-term follow-up for a year. Some of the patients that continue their apomorphine, and some of the patients who were on placebo were switched to apomorphine and continued on apomorphine. And what was seen in the combined safety results for all patients entering the open label study, you can see that 16.7% of the patients had adverse events that lead to study discontinuation. And in 4 patients, that was infusion site reaction, in 2 fatigue, 1 with we already know that patient with hemolytic anemia, 1 delirium, 1 dementia, 1 disturbance in attention, 1 lymphoma, probably not caused by apomorphine, 1 nausea, 1 panic attack, and 1 with somnolence. And then there were a number of patients with local intolerance, but it was about 70%. But again, only a few patients dropped out due to the skin reaction. And this is another way of looking at the side effects. They are divided here into mild, moderate, and severe. And as you can see, there are a number of mild side effects, some moderate, but very few severe side effects in the open label follow-up. And this is to show you that the effect on the off time continued. So the green bar in the beginning of the graph would be the patients who were on placebo in the beginning of the study. And by week 12, they changed to apomorphine. And you can see the reduction in off time when they were switched to active treatment. And this reduction actually continued, and there may be a trend that it continue to get better as time continues or goes by. And this is looking into patients with on time without troublesome dyskinesias. And again, you can see the same. When patients change to active therapy, there was more on time without troublesome dyskinesias. And this continued within the study period. So a few words about adherence. Now we know how to stop the patients. How about making sure that the patients stay on the treatment? I'll just share one study with you, and this is a retrospective study from Italy, comprising 114 patients. And this is the Kaplan-Meier curve or plot on the patients. And you can see that there is some change. The patients who are older are dropping out in a faster rate than the patients who are younger. And the younger patients are those who are less than 69 at the study period. And now I'd like to share with you why the patients dropped out. In a bit more than 40 of the 114 patients, they dropped out due to lack of improvement of dyskinesias. And there could be an element of lacking the audacity to reduce the peroral treatment enough. in this. We know from a number of older studies that centers where the patient continued to have dyskinesias were centers that were prone to have a small amount of apomorphine during the daytime. That is, the amount of peroral treatment was higher than the centers that had more patients who had severe or significant reduction of dyskinesias. The next problem would be cognitive impairment. 15 patients or 16 patients dropped out due to that. Some skin reaction, but the number of patients who dropped out to skin reaction would be about 10%, and that's not that many. Worsening of posture, psychosis, yes, certainly. Depression, anxiety, and then a few patients with hypotension and other problems. So, is it possible to give apomorphine as monotherapy, as we see in Duodopa, which is used as monotherapy? Well, I'll like to turn your attention to this small study from Poland. It was 9 patients fulfilling the CAPSID protocol for having deep brain stimulation. But the patients refused deep brain stimulation. Instead, they accepted to be included in a study where they are treated with apomorphine infusion therapy as monotherapy for 5 days. These patients are selected. So patients with severe psychosis, impulse control problems, severe disabling dyskinesias, dementia, symptomatic orthostatic hypotension, or cardiac problems were not included. For all of the patients, all of the 9 patients continued with within the 5 days. So maybe this should give us courage to aim for monotherapy in more patients. But when should we start considering device-aided therapies, and with that, apomorphine? To show you why I think this question is relevant, I'd like to share this study from a NETRAX group from 2006. They looked into the Kaplan-Meier curve on surviving in terms of staying on the working market. So patients who were offered advanced therapy, in this case, deep brain stimulation, had Parkinson's disease for about 15 years. And at that time point, virtually none of the patients were still working. So based on this, the early STIM study was introduced, and that gives us courage to operate patients at an earlier stage. And there is a study on Duodopa as well, where patients are offered Duodopa treatment earlier on. And we looked into this. This is a Danish, Swedish study where we looked into patients receiving device-aided therapy. So patients were on Duodopa, apomorphine, or deep brain stimulation. But we looked at a subset of patients, patients who were 65 or younger at the time when they had the treatment. And we tried to look into how many of the patients stayed working after a follow-up period of 5 years. And sorry, this slide is a bit busy, but the result was that more of a greater number of the patients actually continued working than you should expect from the graph I just showed you from a NETRAX group. So this again should remind us that maybe we should start the treatment at an earlier age. There are other ways of giving apomorphine than the infusion therapy. The pulmonary route has been tried, and actually it was shown to be very effective as a rescue medication. But there's not any ongoing development of this drug as a dry powder. The sublingual route has been carried out again as mainly rescue treatment, and it is developed. It is effective, and I believe in some of you may have it available in your country. The transdermal route is being explored. It's not yet commercially available. Neuroderm is still doing developments on this. And this is just a study which is still ongoing a few weeks from now. It will terminate, and it's looking at the effect of apomorphine pump treatment on sleep problems. And I very much look forward to getting the results from this study. So to conclude, we now have evidence from RCT studies that the effect of apomorphine is significant on motor fluctuations in patients with advanced Parkinson's disease. Infusion site reactions were frequent, but it was a rare cause of cessation in the Toledo study. And maybe there are fewer neuropsychiatric problems than we expected. It was relatively rare in the Toledo study. And maybe to increase adherence, we should pay close attention to the skin of the patients to try to avoid problems, the formation of skin or even infection of the skin. And we should have close attention on the total medication the patient is in. We should try to continue increasing the apomorphine load and decrease the peroral medication load. Maybe in some patients we can aim for monotherapy, but I don't believe it will be feasible in all patients. And maybe we should consider giving advanced therapies, which could be apomorphine at an earlier stage, and maybe the future will bring us other routes to use apomorphine. Thank you for your attention.